Hello, I'm Dr. Safarpour, and tables are turned now, and I'm patient Safarpour, Damoun Safarpour, and if you're wondering about my accent, I'm Iranian. We call ourselves sometimes Persian, just to emphasize on the heritage and great past history. So I am an oncologist, and 6 months ago I was diagnosed with metastatic colon cancer. So I was prescribing chemotherapy for patients every day, and now I'm receiving chemotherapy. I was supervising chemo infusion center. Now I wait in waiting room to go to chemo infusion center, and most of the time I'm the youngest patient there. Average age of patients in the waiting room is 60, 70, 80, 90. And yeah, it's just very difficult. Been very difficult 6 months for me. I would like to share my journey with you. Perhaps some of you may have colon cancer, metastatic colon cancer, and also your families have insights as an oncologist. So I will share some scientific data with you, and also the from patients' perspective too. I've been searching YouTube videos, and I came across some of these videos of patients with metastatic colon cancer. Many of them recorded videos a few years ago, and they're gone. Unfortunately, there are a few of them alive, especially if they're on immunotherapy. And so, yeah. So for colon cancer, we have, like any other cancer, we have a stage 1 to 3, and then we have a stage 4, which is metastatic. A stage 1 to 3, we try to cure patients with surgery, and after surgery, we give chemotherapy to some of them, mostly stage 3 and some stage 4 patients. And for stage 4, we cannot cure, unfortunately, unless they have limited stage 4, which I will talk about, and mostly it's palliative chemotherapy or other targeted therapies. Um, so the backbone of chemotherapy for metastatic disease is 5-FU, which is a pump attached to the patient's body for 46 hours. It's been there for more than 20 years, and ironically, we're using this same chemotherapy for the past 20 years. They say that we're really progressing in, finding new treatments, but in reality, there are just minority of patients that are eligible for these targeted therapies and immunotherapy. And immunotherapy for colon cancer, metastatic colon cancer, is only works in the 3 to 4% of patients called MSI high patients. Basically, they check 4 proteins in the blood, proteins from the tissue, and there are other ways of measuring these proteins too. And if you're missing one of these proteins, they call you microsatellite unstable or MSI high, and then you're eligible for immunotherapy, which is only 3 to 4 the percent of patients. And why I'm talking about these, because immunotherapy can do the miracle for you sometimes. And even if you have a stage 4 without any surgery or radiotherapy or anything else, you may find a cure, because that's the way with immunotherapy. But if you're not eligible, like most of the patients, like 96, 97% of the patients, you're stuck with chemotherapy and or other targeted therapies. Other targeted therapies are HER2 targeted treatment, which is, I think it's about 5% if I'm not wrong. I have to mention I'm a general oncologist. I'm not a GI oncologist. So I try my best to give you some information, but please take it with a grain of salt. So the numbers may be a little up and down, but I think HER2 is 5% of patients, and they add HER2 targeted treatment, either first line or second line. They're looking at them. Then there are other targeted treatments. If you have KRAS 12C mutation, there are targeted treatments like sotorasib and adagrasib and etc., which they combine it with cetuximab. They're all fancy names, and you may hear the trade names. I go with the generic names, and yeah, what else? And then yeah, these are the treatments. So the backbone I was saying it's 5-FU, and then they add oxaliplatin to it, and the combination of 5-FU and oxaliplatin is called FOLFOX. If you're a colon cancer patient, you're very familiar with this term. FOLFOX usually is used as a first line of treatment for metastatic cancer. Also, it is used as the adjuvant treatment for stage 2 and 3. Means that adjuvant means that you have your surgery, and after surgery you will have chemotherapy, and that chemotherapy is called FOLFOX. The other combination, and also in metastatic cancer, is also FOLFOX. Usually you get 8 to 12 cycles of that, and your oncologist will remove oxaliplatin and continues with 5-FU plus likely bevacizumab or other medications. Why they stop oxaliplatin? Because it's heavy, it causes fatigue, and then it causes neuropathy, tingling, numbness of your hands, which I have right now. And so it's also for the sake of quality of life, because after 8 to 12 cycles, you're exhausted, you don't have your quality of life, and then you want to break. And then also the efficacy after 8 cycles usually is gone. So most oncologists, they do not use oxaliplatin more than 8 cycles, which translates into 4 months. So yeah, the other medication they use it with is bevacizumab. They usually use it with FOLFOX plus bevacizumab. Then they, as I said, they remove the oxaliplatin, then they continue with bevacizumab and 5-FU pump. That's called maintenance. It means that you just continue and continue till it's working. It means they repeat your CT scan every 6 weeks, every 2 months, every 3 months, and check the lesions and compare them to the last CT scan. If the lesions are not growing, we call it a stable disease. It means that it's still holding it at bay, and it's a good idea to continue with whatever you're on. The other regimen used for metastatic setting is called FOLFIRI, which uses 5-FU backbone again, the pump that you wear it for 4 to 6 hours at home, with irinotecan, which is another medication. So here, instead of oxaliplatin, they use irinotecan. And some countries, they use FOLFIRI first, like some countries like Europe, because it's less heavy on patients. Yeah, some countries like US, they use you start with FOLFOX, and then whenever it fails, they go and switch to FOLFIRI. Again, it can be used with bevacizumab. And in the metastatic setting, there are other medications too that can be used instead of bevacizumab, especially if you have a left-sided colon cancer. It means that your primary cancer is from your left side of your colon. And if you don't have certain mutations, including KRAS, NRAS, and BRAF, and then you can use panitumumab or cetuximab instead of bevacizumab. And there are very good medications too. And so I think I'm getting too much into details. It should be a little bit fun, and so you can listen to this. When I read posts from other cancer patients, either on Twitter or YouTube, A lot of feelings are really common between cancer patients. You know, the frustration of this diagnosis when it is first diagnosed, especially if you are a young person. You know, it would be much easier if I was 85, if I was 75 years old, 95 years old. Even you see a patient in his or her 90s, they would like to fight. They want to live longer. Uh, and I mean, some of them, they want to directly go to hospice and comfort care. But a lot of 90s I met in clinic, and they would like to even start chemotherapy because life is sweet, and life, I mean, sometimes is difficult, but in the worst case scenario, it's better than dying. Who wants to die? Nobody. And when you're 85, you're 95, you said, yeah, I had my life. I lived my life and I enjoyed it, and you accept this easier. And But when you're in your 30s, when you're in your 40s, I'm 44 years old. When I was diagnosed, I was 43. So it was very hard for me to accept this because you know, I did a lot of work to become an oncologist. I did, you know, I tell you, I did my medical school back in Iran. That was 7 years. Then I went and I did a master in public health in London. That was about 1 to 2 years, and then I did research at Yale University for around 2 to 3 years, and then after that I did a fellowship in. I'm sorry. After that, I did internal medicine residency, which is 3 years. I did that in Brooklyn, and then after that, I did fellowship in hospice and palliative care. That's funny, and for 1 year, and then I worked as an emergency room doctor at Memorial Sloan Kettering for 6 months or 4 months, and then I did 3 years of fellowship in hematology and oncology. If you add them up, maybe it's like 16 years, 17 years of hard work and study just to become an oncologist, just to start your life as an oncologist. And then I worked 1 year as a temporary doctor in Wisconsin. We call it locum. And then I moved to Tennessee and work with private organization as an oncologist. I worked 6 months here, and then I was diagnosed with cancer, and it was very, very painful. And because, you know, when you're an oncologist, it's hard to give yourself hope. And you know too much. Basically, you've seen it all. I was in hospice and palliative care. I know about active dying. I know what happens. I know about complications, what I'm going to die from, and everything else. So it's just hard to unsee it. It's hard to ignore it. And I know my life expectancy is usually 1 to 3 years. You know, average. On average, you know, approximately around 15 to 25% of people with metastatic colon cancer make it to 5 years. So, yeah, I'll talk more because I think I cannot record more than 15 minutes. So, we'll see you soon.